I warmly welcome everyone to the next SIP of Science event hosted by the Department of Anesthesiology and Intensive Therapy and the Center of Translational Medicine at Semmelweis University. Today's topic is source control in sepsis and septic shock, which will be presented by Professor Jan De Waele. Allow me to briefly introduce our special guest today. Professor Jan De Waele is a surgery-trained intensivist at the surgical ICU, Ghent University Hospital, Belgium. His clinical interests include severe infections and abdominal catastrophes. He has a specific interest in infection in critically ill patients, and his research activities currently focus on optimizing antibiotic therapy in severely ill infected patients to improve outcomes and combat the development of resistance. He currently serves as the president of the European Society of Intensive Care Medicine. Dear colleagues, please submit your questions either in person after the presentation or in writing via chat. Please, Jan, begin your presentation.
Yes, sure. Thank you very much. It's a pleasure being here with you, albeit virtually. I will first share my screen. This should be pretty much it. Please shout if you do not hear it, but I expect no big issues. So the topic of my presentation is indeed on source control and sepsis and septic shock. There was a question mark when I got the original title from the organizing committee, but actually you will see that this should not be a question mark, but a strong exclamation mark, of course. Yes, source control is essential in patients with sepsis and septic shock, and albeit not in everyone, I think you need to consider the need for source control in each and every patient. So these are my disclosures. I've been involved in a number of projects. As mentioned, I am involved with the ESICM and also have a funding from the Flanders Research Foundation. So let's maybe start with the basics, just to make sure that we speak the same language. What exactly is source control? Because people may give you different appreciations, different way they want to describe it. Now, conceptually, because this is more description rather than a definition, it is everything we do to eliminate the source of an infection and to control ongoing contamination. Those are the primary two goals. Yes, of course, it is also important, especially in the abdomen and some of the organs, to also restore the anatomy that was present before the infection occurred and also the function. There's different ways to get to this goal, and typically we may use one or more of these four components. Drainage, debridement. So drainage is removing pus and infected material. Debridement is surgically removing infected or dead tissue that you cannot put where you cannot put a drain. Decompression refers specifically to the abdomen, where this aspect is also important, and definitive repair again refers to restoring, for instance, GI tract continuity. Now, when I say source control, a lot of you would typically think about a situation like this one. This is an intraoperative picture. An abdomen, you see the bowels, of course, and a patient suffering from quite important and diffuse peritonitis. You can see the adhesions between the bowels, the fibrin, the positions, but also here the infected and inflamed fluid. Pretty much an obvious diagnosis when you see it, but of course, it's an easy diagnosis to do intraoperatively, but before the surgery, it may not always that easy. It can be simple, like in this case, for instance. This is a patient who was scanned, admitted to the ICU with respiratory insufficiency a few days after GI tract surgery and an anastomosis. And clearly you will appreciate the presence of a lot of free air. Sometimes also you don't even need a CT scan, like in this chest x-ray, which is more like an abdominal chest x-ray with the diaphragm here and a lot of free air that has accumulated under it, and typical, of course, of a GI tract perforation. So no big issues with diagnosis in some places, but in a lot of them it is quite challenging. I'll come to that later during my presentation. Now, do mind that source control not only refers to what we've seen, the abdomen. This is a schematic overview of the different organ systems and tissues where you may want to consider source control. So yes, of course, the abdomen is there with different organs that may develop infections. Also the heart, the head and neck region, skin and soft tissues, central nervous system, each of them with a specific infection and the source control procedure that may be needed, devices that we put in our patients, chest infections, joint infections, urinary tract infections. So again, please don't think that source control is only relevant in abdominal infections and maybe some catheters. There's many other reasons. And I would even go further and even want to extend maybe the source control to removal of some of the devices. This is the picture I took in one of our patients who had been intubated for a long time. This is how the endotracheal tube looked like. I don't have to tell you that there will be a lot of biofilm, a lot of pathogens here that may actually infer a risk of infection, and removing this biofilm-loaded endotracheal tube may actually also be a form of source control. So while many of you will agree that it is important, have we been able to quantify this? Let's take a dive into the literature. One of the first slides I want to show you is a slide that you may recognize. It's coming from Dr. Kumar from Canada, looking at source control implementation and survival in septic shock. Now, you may remember this kind of figure because, yes, indeed, Dr. Kumar also had a similar picture on antibiotics and the delay and how it impacts survival. You can see that the survival in black goes down as it takes more time for source control to be implemented. And when it's not implemented, in this series, mortality is almost 100%. So clearly, it is important, and also the timing seems to be important. Let's look maybe at a few of the articles on this topic. Quite recent data from the US, looking at the association between the timing of source control and mortality. This was a country done in 14 different hospitals, almost 5,000 patients, as you can see, and they looked at early versus late source control, and early was defined within 6 hours. So this referred to community-acquired sepsis, quite a broad range, broad type of infections, and the median time to source control was 15 hours, and roughly 25%, a little bit more, the surgery or the intervention for source control was actually done earlier. So what was the impact on mortality? Here you can see the odds ratios. So this is for overall population, and you can see that yes, timing was important with an adjusted odds ratio of 0.71. Right. And when we then dive a little bit deeper and look at the more severely ill patients, this is the group of patients where the impact was the most. On the other hand, in patients with low SOFA score, the impact was not that outspoken. Looking at different sites, it appears that the GI tract and soft tissue infections were the infections that have the biggest advantage to have their source of infection controlled early on. They also looked in this study at the different types of interventions and this relation to source control. And you can see here in the upper left part that the longer the time between source control and the onset of infection, you can see that indeed the risk-adjusted mortality goes up. And then specifically looking at, for instance, explorative laparotomy, this relation was actually stronger. The slope of this line is actually steeper. And the same holds true for soft tissue debridement, whereas for drainage, on the other hand, here in panel F, you can see that, well, basically the timing between source control and the onset of infection was not that strong in terms of 90-day mortality. So clearly, different types of infections, different severity of diseases, different modalities gets you different results. Let's now look at another study. This study comes from our colleagues from Korea, looking at patients with septic shock, multi-center observational study, you will understand that this is not an area where you can expect a lot of interventional studies, albeit just a few minutes, I will show you something. So 11 centers, more than 2,000 patients, septic shock presenting to the emergency department. So specific subgroup, right? 23 of these patients required source control. Overall mortality was 20%. And as the interval of between presentation and the ED and source control was higher than 12 hours, mortality went up. Of course, septic shock presenting to the ED may be different from our patients in the ICU. And indeed, when you look, for instance, at the infection source in this type of patients, the majority of them being hepatobiliary, some GI tract, some urinary tract. So it's a mixed bag, basically. Then, more specifically, they also looked at the timing of source control in a multivariable analysis, and they looked at both 6 hours and 12 hours. So 6 hours on the left-hand side of the panel, 12 hours on the right-hand side of the panel. And there was, in this series, actually, well, there was a trend, but it was not significant relation with the outcome, which was 28-day mortality here. So some data supportive, other not so much. In a recent study, I'm trying to summarize the recent literature, and this is a graph, table summarizing these studies. Now, first of all, when you look at the recent literature, look at the definition that was used for early source control. And you can see that it's different, sometimes 6 hours threshold, sometimes 12, 16. Look also at the patient population, and in different studies, it could be either intra-abdominal, community acquired, ICU patients, emergency laparotomy for specifically perforated peptic ulcer, cholecystitis, septic shock in the ED, sepsis or septic shock in the ICU. So again, a big mixed bag. And no surprise, there were differences, albeit the studies showing an advantage of early source control highlighted here in green, whereas the gray studies actually did not show any benefit. But the majority of the studies, as you can see, a quite substantial, quite often quite substantial benefit for early source control. In this case, like decreasing the mortality by half. So yes, it seems from this that there is quite a case for early source control. Now again, these are often very specific patient populations, and some of them may be more severely ill. I mentioned that there would never be a randomized controlled trial in this domain. Well, I was wrong. This is a study. It is not, of course, on ICU patients, but it is a problem that is quite common in the patients with acute appendicitis, uncomplicated acute appendicitis, which may be a frequent reason for surgery outside of office hours. In this Finnish study, they studied almost 2,000 patients. They were randomized. 3 hospitals in Finland. They randomized between early source control, which was first early surgery, which was within 8 hours, versus within 24 hours, which has quite substantial logistical consequences, of course. Mortality, as we would expect, was low, 0 mortality. Complications were comparable. So this was a non-inferiority randomized controlled trial showing that depending on the patient, indeed, you may not have to run to the OR to operate on those patients. And here probably also, again, the severity of illness part will be play an important role. So looking at all of the literature, some caveats. First of all, observational data when we talk about sepsis and septic shock. And I don't really expect an RCT as they did for acute appendicitis being done in ICU patients with sepsis or septic shock. Patients highly variable in different studies, often selected or highly selected patients. But also mind you that the interventions as well as the infections may have been different. The efficacy of a percutaneous drainage versus an explorative laparotomy, as well as the complication rate, may be different. So how to interpret all of this? I do like, to keep things simple, and for me, it is quite simple. And for me, within the sepsis treatment pyramid, source control is, the basis of everything. If you want your antibiotics to work, and especially if you're doing research on sepsis and you want your new sepsis wonder drug to work, you'll better get your source control and your antibiotics correct. So this is an oversimplification, of course, but it shows how important source control likely is. Now, source control is important to increase survival in severely ill patients, but it is also a way to limit antimicrobial overuse. In patients whom source control is not possible or not obtained early, antibiotics, may be futile in many of these patients, and eventually just leading to multi-drug resistance, which then again will lead to the need for more and more broad-spectrum antibiotics, and leading to persistent peritonitis, etc., etc. So early source control is in a way also an antimicrobial stewardship intervention, because it allows you to limit your antibiotics, and you will be avoiding the development of multi-drug resistance big time. So how does it translate to the guidance? I'm citing you from the 2026 update of the Surviving Sepsis campaign, published 3 months ago. This is a QR code. It's freely available. Just zooming in on the source control recommendations. Source control, 2 recommendations on source control. The first one being a good practice statement, meaning that there is no solid evidence to support it, but it's like a sensible thing to do. And it says that those patients with sepsis and septic shock need to be evaluated for a specific anatomical diagnosis that requires source control, emergent source control. So this, circles back to the figure I've shown you with all the different sizes of infections. So yes, also in a patient with a chest infection or central nervous system infection, who may have an extraventricular drainage of some sort, may also need source control. So yes, source control is important. And as to the timing of source control, there is a conditional recommendation, which means that this is applicable likely to a big part of the patients that we are treating, saying that for patients with sepsis or septic shock and who have an anatomical diagnosis that requires source control, early source control, that is within 6 hours, ideally, is suggested over late source control. Of course, there's a number of things we need to keep in mind. Yes, the data support this, and yes, absolutely prolonged attempts to stabilize the patients with ongoing infection, especially skin and soft tissue or severe abdominal infection, may not be possible. This idea like, well, I will first stabilize the patient, maybe you'll never get there, right? And this is important to consider. And patients who require source control should, yes, absolutely be evaluated for it. There are a few things to consider. You may want to prefer to postpone surgery, for instance, if a skilled surgeon for specific more complex infections is not available. So sometimes it may be advisable to delay it a few hours, because by then a skilled and experienced surgeon is available. I would rather have an endocarditis, for instance, being operated by a skilled surgeon rather than by a junior resident, just to give an example. So what are the important aspects of source control? I already alluded to one of them, but I think there's 3. So the timing, but also the strategy and the adequacy. The efficacy of source control is critical, because sometimes we put in a drain in one of the many collections and we think we have controlled the source of infection. We may have controlled one of the many sources, but it needs to be adequate. It's just not about doing the procedure. So timing, I've touched upon this. What determines the timing? I think for me, it's 3 different elements: the presence and the magnitude of ongoing contamination, typically a ruptured bowel that keeps pouring stool in the peritoneal cavity; the degrees and the dynamics of organ dysfunction. Severely ill patients or patients that deteriorate very rapidly before your eyes, as you may see in skin and soft tissue infections, necrotizing infections, those are the ones you do not want to delay. And also patient physiology, of course, is important. We need to consider that some patients may have been deranged metabolically to an extent with which surgery would not be safe within the next hour. So we need to do some degree of correction and trying to correct for these metabolic derangements, or coagulopathy requiring some form of therapy as well. Now, overall, some time ago, we've defined this three-tiered approach to source control. Tier 1 being the patients who require source control immediately from the time you diagnose or you suspect this. Typical, again, necrotizing fasciitis, intra-abdominal, abdominal width compartment syndrome. You do not delay resuscitation. This resuscitation can perfectly continue in the OR, and it's not something that stops at the door of the OR. Tier 2, as soon as patient physiology allows, and this is, patients with sepsis, septic shock within 6 hours. Now, stable is not always normal, and please realize that patient can be stable but not hemodynamically normal and fit for surgery. This continued resuscitation, of course, being critical. In this category, secondary to peritonitis, pleural empyemas, cholecystitis, and a lot of the infections that you've seen, most of them, in fact. And tier 3 holds a category, which is kind of a special category, where you want to wait a little bit before doing the source control until the process has somehow demarcated, that the process has been encapsulated and you can put it in a drain or you can do some enterostomy, whatever. Typical scenario is patients with acute pancreatitis that got infected, where you may want to wait a little bit. So the three-tiered approach, which could be helpful. So that's those are basically the key strategies. Now, when to choose what? Because we have, as I've mentioned here, timing, but also the strategy. How important is the strategy and what strategies are available? So we have to basically make a choice between, well, it used to be 3, but it's 2, but it's 3 options now. Percutaneous drainage is probably the primary choice for many patients in the ICU, but it should not always be the case. I mean, some situations you need surgical drainage or another approach. But in situations such as the hostile abdomen, where there's a lot of adhesions and the surgeon fears adding more damage rather than solving solutions, this is not a thing to do. Surgical drainage may still be needed in selected patients. Diffuse peritonitis, the failed percutaneous drainage, and I think from the time you have 2 or more procedures required to try to solve something and doesn't work, you may want to do something else. And a new kid on the block is the endoscopic strategies: stenting, suturing, clipping things, endoscopic vacuum therapy for esophageal perforations are all options for endoscopic treatment. So how do we decide? We decide based on the hemodynamics and a number of patient-associated factors, but also, of course, on hospital factors. OR availability, I've mentioned the importance of the surgical experience, the endoscopy or percutaneous drainage experts' availability. There are many obstacles, and I see 2 important ones. A delay in diagnosis, and this can be due in the ICU due to the fact that there's no clinical symptoms or not enough. There's other infections that blur the picture, or we may not have the right diagnostic tools. Delay in therapy is equally important, and here especially this perceived need to have more investigations. Do another CT scan. I've shown you the picture with the subdiaphragmatic air. You don't need additional CT scans to diagnose that there is a problem. But also, again, access to OR or to interventional radiology. The final aspect, the adequacy. Adequacy of source control is critical. You need to remove as much as possible of the infection. And when is that not possible? And that's one of the critical things and difficulties also to recognize in patients in the ICU. So how can we recognize failed source control? Sometimes it is easy. When this comes from an abdominal drain, this is not a good thing, right? You will recognize the green brownish discoloration, clearly small bowel content as far as I see it, and this is not normal. Whenever a drain from the abdomen drains something that is green or brown or red, those are the bad colors. right? It can be something else. Here it is more bile, brownish, yellowish brownish, this coloration, a bile leak from the abdomen. So source control failed clearly, but it's not always that easy. And how can we use, clinical factors or something? Very interesting study in this context comes from this analysis from patients who were included in the MARS study in the Netherlands. And patients who required source control were specifically studied. 25% roughly were percutaneous procedures, the rest were surgical procedures, and 50%, like half of them, required more than one intervention. So that is quite substantial. So here you can see the number of procedures for both surgical and percutaneous procedures, and you can see that, yes, indeed, a substantial number of patients needed repeat procedures, up to more than 7 in some cases. Now, when these investigators tried to look at the characteristics of patients with failed source control or inadequate source control, roughly 1 out of 3 had adequate source control by day 14. 1 out of 3 had delayed adequate source control. And in 1 out of 3, it was still impossible at day 14 to have adequate source control. So it is something that is quite common. And when your surgeon friend tells you, like, well, the source is controlled in this patient with septic shock, roughly 1 out of 3 times he will be right, 1 out of 3 times he or she will be wrong, and somewhere it will be in between. Also quite striking when you look at the first row, you can see that in almost all of these procedures, the immediate procedural adequacy, which means that the surgeon or the operator said, like, this is going to work, this is going to not, we won't have to come back again. So also in patients with failed source control, 92 and 96% of the situations, the surgeon after the procedure said, thumbs up, this was a good thing. So be just suspicious when this is happening. Looking at different characteristics of these patients, these are trends in CRP, white blood cell count, SOFA score, trying to differentiate between adequate, delayed adequate, and inadequate. And basically, it's all quite similar. Only the patients with persistent elevated SOFA score was probably the most reliable indicator that something was wrong. Patients with adequate source control, SOFA score went down. So how do you diagnose it? In my clinical practice, I use 3 things. Clinical picture, which is basically organ dysfunction. Biomarkers can be helpful, but be very careful with biomarkers. And imaging. Imaging has a very important role, but only directed and based on clinical picture and trends of biomarker. So my clinical algorithm here, when I see patients with sepsis or septic shock, of course, no delay in antibiotic therapy and tissue perfusion. You will resuscitate this patient, but in parallel, a process starts trying to identify the source of the infection. The source of the infection is critical, not only to make proper antibiotic choices, but also to answer the question whether source control is necessary. And then based on number of characteristics, you decide on the timing, where you want to do it ASAP for septic shock. You choose on the modality, looking at the type of the infection, the location, and anything else that I've mentioned. And at the same time, you also decide how you want to follow up on this patient. What will be the marker that makes you suspicious that something is wrong? And trying to identify early on how you will be monitoring the patient is critical. Of course, source control is something you cannot just do by yourself, but don't be fooled. The surgeon still is your friend. You will recognize your surgical friends immediately. And if you ever wondered why this is an S on the chest here, of course, this is the S for surgery. So in conclusion, dear colleagues, source control, yes, it is critical. It is pivotal for many, many infections, not just those from the abdomen. The outcome is determined by a number of things, but 3 essentially: the timing, the strategy used, and the adequacy of your source control procedure. There is a benefit of early intervention, leading to a conditional recommendation in the latest surviving sepsis control guidelines. This is, pretty uniform across infection types and patients' phenotypes, but there are subtypes of patients that may benefit more, like patients with abdominal and necrotizing skin and soft tissue infections, as well as shocked patients. So those are the two categories the two elements you want to consider. I do still believe that absolutely source control and maintaining source control is a multidisciplinary thing. And at the same time, the decision-making and modality as well as timing needs to be tailored to the patient. So with this, I would like to end. I'd like to thank you for your attention and happy to take any questions if there are. Allow me to stop sharing my screen. Yep. Here we are again.
Yeah, hello, Jan. I'm back. It's good to see
Hey,
you.
Zolt.
Good to see you. Thanks very much. An excellent lecture on a very important topic. And I just wonder if there are any questions from here, from the studio, or from those who've been following us via the Zoom. But until everybody else is thinking, you put a lot of emphasis on the clinical picture, the SOFA score, as the main guidance to do a surgical intervention or do a source control. And what in my experience is very often overlooked when there is a patient with a chronic critically ill condition. So a bit of ventilatory support, minor need for or on-off need of very low dose vasopressor, and then the intensivists lose their patients and they keep searching for a source, although there is no sudden change in the clinical picture. And I very often stand between my colleagues and the surgeons that I don't want the surgeon touch this patient, because doing an unnecessary intervention, just looking at it, it can cause a potential harm. So you didn't mention that. Could you please elaborate on this a bit? Unnecessary, or what would you consider as unjust surgical intervention, and what is the harm it can cause?
I fully agree, Zolt, that indeed surgery can also be harmful for patients. I don't know how it is in your country, but in my country, I must say that surgeons have become very, very careful with attempting to go in this type of abdomen. It used to be different 30 years ago or 25 years ago when I was in surgical training. We did a lot of laparotomies that in the end were not likely to be beneficial, probably caused a lot of damage also. There was also the time when patients were sent back to the OR every 2 days to do the Etappenlavage, and like the Germans invented the concept. But then randomized controlled trials showed that this didn't offer any benefit, probably did more harm, as you mentioned. So I think based on that, the mentality has changed. At the same time, of course, the diagnostics have also improved greatly, and the ease of which, of course, we have CT scan available now. We can do ultrasound, so we can do many different things. Surgeons often have, also lost the skill to operate on this kind of patients, because a lot of the surgery is avoided now with percutaneous drainage. So we've shifted away. I think at points a little bit too much. I'll give you an example. The acute pancreatitis studies, the step-up approach that was done in one of the first studies of the Dutch group, in which they randomized the patients to open surgery or a step-up approach, in which first a percutaneous drain was placed and only then an endoscopic procedure, well, not an endoscopic procedure, a retroperitoneal approach with endoscopic techniques was used. In this last group, the mortality in patients who needed eventually to have this debridement with the surgical approach had a higher mortality, and mortality comparable to the open surgery, suggesting that you should also not delay surgical procedure in patients who need it. If you start with a percutaneous drain and only do the surgery 2 weeks later, that may also be harmful. So I think the jury is still out, and I think maybe the pendulum has gone a little bit too much to the other side, like surgeons saying, like, I don't want to operate on anything anymore, don't call me. Especially again with these esophageal perforations these days. We treat many of them with endovac. It used to be open surgery before, which also had a lot of complications. But now the odd patients that does need surgery may get it quite late and also suffer from that. So I think should be individualized for sure, and I think all options should be on the table. And yes, of course, always try with minimally invasive, but if it doesn't work, don't try for weeks and weeks with an additional one, another additional one. At some point, proper surgery may be needed.
Okay, any other questions?
I was thinking on our patient population where we don't have the post-abdominal surgery patients that only a few times. But I have to say most of our patients at one time of their course of illness, they have pulmonary sepsis. Even I would say that 50% of our patients comes with by default pulmonary sepsis and septic shock. And would you consider the bronchoalveolar lavage is a very contradictory way? Would you consider it as a routine to debride the many the many bacteria and is it a source control or do we cause harm?
Yeah, I see your point there, and indeed, of course, the thing is where do you set the boundaries of source control? In your specific example, I think that may be probably for now not evidence-based, as in I haven't seen any studies that have shown this, albeit and maybe not so much bronchoalveolar lavage, but specific patients with massive secretions and maybe atelectasis, to do an endoscopy without necessarily lavage, but more the procedure of removing massive sputa could be. This is a gray area, clearly, but I do challenge the conventional thinking of source control is only in the abdomen. I think there's many different ways, and as the endotracheal tube that I've shown you, I think there's many situations where we have biofilm forming and maybe inadvertent causes of continued infection. But I would not go as far as saying we need to do BEL on all of those patients. I think if it's massive sputa, maybe in some situations that could help. But again, this is a hypothesis. It hasn't been properly tested. But when you've seen a patient with severe CAP, I can think of patients who may have benefited from such a procedure.
Do you use bronchoalveolar lavage to collect samples anymore?
No, we don't.
Yeah, thank
well,
you.
not routinely. We do it occasionally, typically in immunocompromised patients with uncertain diagnosis, etc., but not like our French colleagues as a standard of care to diagnose or to also use the quantification, etc. That's something we do not do.
And what is your opinion on using after emergency abdominal surgery antifungal treatment as a routine?
Something we do not do unless the patient has been exposed to antibiotics for a long time. Typical scenario would be a patient with a GI tract leak 1 week after surgery, who was in the ward, who has been treated with Piptaz for 5 or 6 days. This patient comes in with septic shock, then we will cover fungal infections, so candida infections. There have been a number of studies on that, and not a single one was able to demonstrate a benefit. So no, we don't routinely do it.
Yeah, in the meantime, we have a question, but only regarding the recording. Emma asked whether it is
I see
recorded.
there's
Yes,
an
it
online
is.
question.
Oh,
Christina.
oh, I
Thank
can't
you.
see it.
Thanks very
Well,
much.
it's a hand, so I assume it's a question. I don't.
Yeah. Thank you so much for this great overview. I would ask a practical question from your everyday life. So most of the source control operations for sepsis are done out of hours in many of the cases. And it would require a very good collaboration between intensivists, radiologists, and surgeons. And sometimes the institutional inertia is quite big. How can you overcome? Do you have a strategy or protocol that you would recommend to overcome this delay and inertia in the emergency settings?
Yeah, that's a difficult one, of course. It depends very much, of course, on the level of engagement of both surgery and interventional radiology. I mean, those are, for me, the two primary partners in this thing. What we typically do is involve them at an early stage when we think we need their advice before the CT is done, and speak to them and. But at times, especially for interventional radiology, who are quite busy out of office hours with strokes and subarachnoid hemorrhage treatments, etc., that can be challenging. I must say I can understand that indeed in not septic shock patients, we can delay a procedure for a few hours. I don't have any issues with that. But then again, in shocked patients with abdominal infections, I would not tolerate any delay more than a few hours. Of course, again, if the OR is full, if there's no rooms available, okay, then this is an urgency. If there is something, if the trauma patient comes in, then that patient would get the priority still. But it's having them on board and keeping your surgeon as a friend. And it may have come across as a joke, but it's not a joke. You need to speak to them. You need to show them that you're both committed to improving sepsis care. And if you have, I don't know how the setup is in your countries, but if you have like antibiotic stewardship teams or policy groups, then you need to get them there on board. And while you discuss antibiotics and how you treat patients with sepsis, emphasizing the role of surgery. And I don't know if there's any surgeons in the room or listening here, but you will know, of course, that surgeons like to be in the center of the attention. And if you tell them how desperate you need, or the patient needs the surgeon, then I'm sure that that may help.
We have pancreas teams that work quite well because it's very difficult to decide when to operate on. And as the radiologists, surgeons, sometimes infectologists and intensivists are in the same team in a Zoom, just like now. Sometimes it's much easier and quicker to arrange the operation of a patient if everybody involved is in a conference talk very quickly. So do you have similar for sepsis, for example, or it's just very good connection, and if the intensivist call them, then it goes easily?
Yeah, we don't have anything specific for sepsis. It is also quite challenging because you have really the full array of surgical specialties, from head and neck over neurosurgery, thoracic, vascular, abdominal, and even within the abdomen. In my institution, you have, I think, 4 categories by now of, the left lobe of the liver, the right lobe of the liver. I'm exaggerating, of course, but you see where this is going, and it's very difficult to select these days. The hyper specialization in many centers makes it more challenging, and this concept of general surgery, who covers basically anything, has gone. But you have the urologists, you have the orthopedic surgeons, and then within the orthopedic surgeons, you may have the spine surgeons for spondylolisthesis cases. It is quite challenging, and we don't really have a single point of contact for that.
Yeah, thank you. Yeah, I was just thinking about this because sometimes we lose very precious time with just the telephone calls and getting everybody on the boat. So yeah.
Yeah, but it is important, I think, to have your flows ready, and you know how it works. Often you have somebody within a surgical department that you have good connections with, or you work with more than with others, and that's all things that can help. But this is typically, I think, dependent on the hospital, the way it's been organized, the size of the hospital, many different factors, I think. I think there's no standard one-size-fits-all approach in here. It has to grow somehow organically, I think.
Yeah. Thank you.
And we just
Pleasure.
received a comment from Suhaib Khan that surgical debridement could cause worsening of septic shock, cytokine storm, etc. What have you found? I think we touched this, haven't we, Jan?
Well, not specifically on the inflammatory response. I know that in some surgical myths there is this concern. I think, of course, it is important not to cause more damage. Acute pancreatitis surgery back in the 1990s was an example of how you should not do things, trying early on during the disease to remove all the inflamed tissues by simply thinking there's a lot of bad stuff around the pancreas. Let's remove all the bad stuff, including the pancreas, and the patient will get better. Well, patients didn't get better and they bled to death. It's just one example, I think, where we need to be cautious, we need to be careful in some situations. And again, depending on the anatomical diagnosis, for pancreatitis, it's just due to the complexity of the anatomy and all the vessels running over, in, through, around, above the pancreas that make any surgery there high-risk procedure. It's different when you have a subcutaneous necrotizing infection in the lower leg, then you can go straight there. So I don't know of any evidence, clinical evidence, supporting the hypothesis that doing surgery is kind of a risk or infers a risk of inflammation. I don't think that is the case.
Well, thank
If that
you.
is an answer to your question.
I think so. Well, our time is up. So, Jan, we are really grateful for taking your time. And thanks very much for those who logged in from outside Hungary. There are a lot of guests from other countries. Yeah, so it has become really an international meeting. And all of you who did not have the chance to be with us now, it will be soon on YouTube. We will send you the link via LinkedIn and via our mentoring network. So please share it with everybody else. And thanks very much for the Translational Medicine at Semmelweis University for providing us with all this technical setup. And especially to you, Jan. So hope to see you soon somewhere on an internet conference. And thanks again. Thanks for everyone. Have a nice day. Bye-bye.
Take care. Bye-bye. Bye-bye.